Good evening, everyone, guys. Hello.
Good evening, Mr. Mani.
Hi. So, welcome you all for this the Taster Viva session. To introduce myself, I am Manikandan Kathirvel, one of the consultant HPV transplant surgeons working at the Whittington and the Royal Free Trust. So, this Taster Viva session is done as a part of. Let me mute. Qasim, I'm going to mute you. It's because it's echoing. Yeah. Yeah. So this test waiver session is done as a part of our 8th FRCS course, which is about to commence this weekend. So before the commencement of every course, before every exam diet, we used to conduct this test waiver sessions mainly for the course candidate as well as anyone who is keen to give these exams or looking forward in the future to know something about this exams. That's the whole purpose of conducting this test waiver sessions. So today we are planning for 2 hours, and same time tomorrow we are planning for another 2 hours. The objective of these 2 sessions is not to test you. I'm not going to be very strict with you. We are not going to have very tough scenarios here. I'm not going to time you, but the whole purpose is for you guys to understand to some extent what is this exam? What is this exam? What kind of or what types of questions you could get in the exams and what is expected from you. That's the most the main objective of these 2 days. Of course, we won't be able to cover everything that is necessary, but you will be having some taste of what is this exam all about. Okay, so the success in this exam is not just the knowledge. I think most of you would know by this time. Okay, so having cleared the section 1 FRCS exams, there is no doubt that you all have the enough knowledge to appear for the section 2 exams. So there is no more additional knowledge which is needed for FRCS section 2 exam more than what you acquired through section 1 exams. So 50% is knowledge, but the rest 50% tests your the life skills which you would exhibit if at all if you get such a scenario in your day-to-day practice. That's what they're going to test you in this exam. In other words, it is something like a consultant interview in the UK, where you will be thrown as a consultant in a difficult scenario and see how you make decisions in that difficult scenario, making sure you make a safe decision, thinking about the patient's best interest. So that is what is being tested here. So unfortunately, in this exam, the main key factor is the time. So this is a time constrained exam in which where you are given very short time in each of the scenarios, and you are tested within that short scenario on whatever I had told. Within that short scenario or within a short time span, you have to exhibit whatever knowledge you have. You have to exhibit whatever clinical skills you had gained over a period of last 10 years in that particular scenario. You have to exhibit how safe you are in your practice. You have to exhibit how you interlink all the departments which handle this patient. So many things are tested in this short span. And also, most importantly, you have to communicate whatever is your thought process in a clear and concise way so that the examiner would understand what is going on in your mind. So that is exactly is what is tested in this exam. And that's why this exam, if you see, lots and lots of preparation is needed. It's not that just because you are a very knowledgeable surgeon, it doesn't mean that you will pass this exam. What is essential is you have to understand this exam, and you need to know all the essential Viva techniques. There are certain shortcuts. I would not say shortcuts, but there are certain things which we keenly look into when a candidate performs. So you have to understand what the examiner is looking for in a particular scenario, and you need to identify that and answer that. And there's no room to waste any seconds in the exam. Every 10 seconds or every 5 seconds would change the entire results from pass to fail. So you need to utilize your time as much as possible and try to demonstrate what you have acquired in the last 10 years in your surgical training. And you clear this exam, to become a consultant. So this is a consultant entry which is being tested. So this is what I want to give as a brief introduction. So what I'm going to do today is I have like 10 to 15 scenarios, which is not very complex. At the same time, it's not very simple. So I want some volunteers to come forward, and I'm going to put forward the scenario. I'm going to question them for a period of 7 to 8 minutes. At some point, I'm going to stop. I might get opinions from others who are in the meeting to give an opinion, and then I will give my feedback. Not mostly on the knowledge, because at this point, even if you don't answer well, that is completely accepted, because you still have exams far away ahead. But what I'm going to give is a feedback on the Viva technique. What I expected and how you performed is what we are going to tell, and through this way, we learn from each other. And if you have any questions, you can raise your hands and we can discuss in between the sessions or at the end of the sessions. But what I need at this moment is whoever wants to participate, I want them to raise your hands so that I will have here, rather than me searching for candidates. You can raise the hands here. So I will have a list of candidates here. You can use your, the symbol there. There is a hand symbol. You can raise it so I can have my list here. Perfect. Good. Right. So I have my first two volunteers. Let me go with Tamir first. And also, before moving on, this session is completely recorded. Yeah. And we will be using this recorded sessions for academic purposes. Okay. And if anyone doesn't want to, have any problems, then it wouldn't be appropriate. So but to be very honest, it's not something I think Qasim has brought on his hand. But don't worry, Qasim, it is not. I'm not going to make you feel bad or anything. Don't worry. Okay, so come forward. Okay, right. Let me start with Tamir. Right, Tamir, you want to switch on your camera if you don't mind? Yes. Right, Tamir. Okay, so Tamir, so you are say, imagine this is a 10-minute clinical scenario in your general surgery. Before going into the scenario again, I want to tell you there are two basic exam components in Section 2 exams. One is the clinical examination. Second one is Viva. Okay, so the clinical examination, you will have one in general surgery and one in your specialty. And then the Viva will be on 4 different topics, which will be general surgery, critical care trauma, academic, and your specialty itself. So you need to understand which scenario you are answering. So you cannot be wasting your time in the Viva scenario. At the same time, you cannot be answering in a short and a crisp way in a clinical scenario. That's the most important thing you need to understand. So the purpose of the clinical examination scenarios in your exam is to assess what is your clinical skills in terms of obtaining history, seeing the clinical signs and symptoms, how you put together, come to a differential diagnosis, how you do your blood test, how do you come to a diagnosis, and how do you manage. That's what is tested in the clinical examination component. While in the Viva, it is straight away just topics. It is just testing your knowledge or testing a particular scenario. So there you are not expected to tell in detail what history you will take, what clinical findings you will see, how do you examine, etc. There it's straight away, it is bang, bang, bang to the topics. 5 minutes each topic, you will be having 5 to 7 questions to answer. So you need to understand in which area which questions are asked, and you need to curtail your answers based on that. Right, let us start with your first scenario, okay? So you are the consultant on call. Assume that it is a clinical scenario exam and it is a 10-minute scenario, okay? And you are sitting in your ambulatory surgical clinic, okay? You have a 62 years old male who is walking into your ambulatory surgical clinic in A&E with history of bilateral groin swelling. Okay, this patient apparently had a laparoscopic bilateral inguinal hernia repair yesterday. Discharged as a day case. Comes back to you today with bilateral groin swelling. How will you proceed? You can unmute your.
So he's coming back with swelling, not pain, just a swelling.
Yes.
And he had elective bilateral hernia repair yesterday. So I will assess the patient based on the CRISPR protocol, make sure that the patient is receiving the appropriate resuscitative measure, including the analgesia. I will have a look on the on his operative notes if available, and then I will take a focused history from the patient regarding the onset of the swelling, course, duration, any pain, any discomfort, when it happened, any discharge, any bleeding from this swelling, um, uh, and then I will proceed for the post-medical history,
Fine.
surgical
So I
history.
am the patient. I am telling you, okay, that doctor, I had the surgery yesterday. Doctor told me that it was a uncomplicated hernia repair. Everything went straightforward. I had the repair on both the sides. I went home. In the middle of the night, I found some swelling on the left-hand side. When I woke up in the morning, I found both the sides. I have a big swelling similar to what I had before.
Yeah,
Yeah, and I don't have much pain.
right. So yeah, I need to examine the patient first, including general examination, abdominal examination, the hernial orifices examination. I'm suspecting that it could be a seroma post-surgery. Hematoma could be if it is a difficult dissection, and less likely recurrence, technical failure kind of recurrence.
Okay, so you examine the patient. So how do you know? So how does a seroma will appear on day one? What do you expect?
A fluid-like kind of swelling, fluctuating, a bit indurated, no impulse on cuff, no cuff impulse. And there might be some skin changes, redness, cellulitis kind of thing.
So you go and examine the patient and you see that the left side, there is a big inguinoscrotal swelling, and on the right side, there is an incomplete swelling, which according to the patient is exactly same as how it was before. Okay. And you are trying to reduce it. It completely reduced on both the sides, and it is not recurring. It is
And
not.
it was
And when he
impulse,
coughs,
there was
nothing is
cough
coming
impulse.
out.
And there was a cough impulse.
No, you reduced it, okay, and it went away, and you ask the patient to cough, nothing comes out. What do you think?
I think it's a recurrent hernia then.
What else it could be, if not recurrence? What do you see in the scrotum when you do a lap hernia repair for a huge inguinoscrotal hernias, if you don't take care of it after the surgery?
What I see in the scrotum after doing lap hernia repair.
Yeah. So after while finishing the surgery, how does a scrotum look like?
Laparoscopically. Will I see the scrotum laparoscopically after the tap hernia repair?
No. My question is, so you are doing a laparoscopic hernia repair. Yeah, a huge inguinoscrotal hernia. There's an indirect sac which you have reduced on by side. You kept a mesh. Yeah. So you are finishing the operation. Okay. When you look at the scrotum at that point, how does it look like before you finish the operation?
It will be a bit retractile, so I have to get it down a bit.
That is about the testis you're telling. What about the scrotal sac itself? The scrotum will be distended, isn't it?
Yeah, some
because
swelling,
of what? Because of the gas.
Because of the gas and because of the traction, because of the dissection.
Most importantly, it's because of the gas only. Because you have reduced the peritoneum, but still gas goes in, you'll have a swollen scrotum, which you will reduce. Okay, so one important differential diagnosis here could be a trapped wind. But in this case, however, you are trying to reduce, the content reduces, and when the patient coughs, content comes out. And you strongly think that it could be a recurrence on both sides. What are you going to do now?
Well, I will confirm my clinical finding by do a kind of cross-sectional imaging.
Why do you want to have a cross-sectional imaging to confirm a hernia?
For the medico-legal aspect of things, documentation of this technical failure. But clinically, it's a recurrent hernia, and it is not urgent to be done in this presentation as long as it is completely reducible. So I will do a CT scan, and then.
So what is the purpose of doing the CT scan in this case?
just for medical legality
Mhm.
and documentation,
Mhm.
but it's a clinical diagnosis.
Mhm. Okay, so you do a CT scan, and the CT scan comes back as left-sided inguinal hernia, right-sided incomplete indirect inguinal hernia.
Right.
So what are you going to do now? This is day one.
Yeah. Well, this patient had completely reducible hernia. I will give him some analgesia, and then outpatient review with whoever did the surgery for him, or one of his team.
When outpatient review, in the sense, you know that if you ask your colleagues to book an appointment, it's going to take at least 4 to 6 weeks minimum to get. So are you happy for the patient to wait for 4 to 6 weeks?
No, I will try to expedite it by talking with the secretary or sending email to them. So that I'm sure that this will accelerate this process. It
Fine.
is important also to discuss the duty of contour with the patient.
Fine. Imagine you are the surgeon who performed this operation. You did the surgery, and patient is coming back to you on day one. What you would do?
He is coming with recurrence, so
Yes.
I will have to do the duty of contour with the patient.
Okay, you have done that. The surgery has failed. Okay, you have told that.
Then I will try to book the patient for the nearest next elective hernia repair.
And what are you going to do now?
Either I will do it another TAP, transabdominal hernia repair, or a kind of Riva stop like of repair, bilateral, or even bilateral 2 incisions.
No,
And
this
mesh again.
patient. So this patient is yours. You are the surgeon. You are the consultant. So you should have one plan, or plan A, B, C. If something fails, something fails, something fails. You cannot have 3 options.
Obviously, it looks like I don't have the laparoscopic skills, and if it is a technical failure like this, so I would prefer to do it open bilateral incisions to fix the hernia.
Okay. Let me move on to Qasim with the same situation. Qasim, you there? Yes, Qasim. So imagine you are the consultant here. Okay, you did a laparoscopic bilateral hernia TAP repair. Okay, patient comes back day one with bilateral recurrence. What are you going to do? Unmute yourself, please. Unmute. You are muted, Qasim.
Hi there, can you hear me?
Yes.
Yeah. So if, as you said, the patient has come back on the day first with recurrence, so after talking to the patient and just 1 second, I have an emergency here. I'm really sorry. My kid has sorry.
No, carry on. Vishal Palmer. Yes.
Hello. Hi.
You tell me.
So yeah, if I see the patient next day in the hospital, that is come back the first post-op day after the lap hernia operation, has got bilateral recurrences. Obviously, after taking into consideration and explaining that it has had the recurrence and apologizing about the fact that it has recurred the first day, I would try to expedite taking him to theaters and get it sorted soon. Firstly, because, and as Tamir said, imaging, and not just for, personally, I think not just for medical legal conditions, I would do the imaging first before venturing into any surgery. First, to check about any other complications in terms of any bowel damage or intraperitoneal, extraperitoneal spillage or collections, which are subtle and not being picked up in clinical examinations. And also because it's such an early recurrence, to check for mesh displacement as well. Whether,
so what will you do?
Sorry, yeah. So just double checking. Was it TAPP or TEP?
It doesn't matter. Why does it matter?
No, I think because if it's
So,
TAP,
okay, if it is TAPP, what you will do? If it's TEP, what you will do?
TAPP, I would be very proactive, because if the mesh has displaced intraperitoneally, there's high chances for it to get entrapped with the bowel, and adhesions and possible sort of a injury to the bowel as well. If it is TEP, the good thing will be at least it is extraperitoneal, unless I've made any.
Then how did the bowel come out then? The bowel has come into the scrotum now already. Do you think the bowel will come without touching the mesh? When even see you, so you need to understand that you have gone and reduced the whole sac, you kept the mesh. Somehow by both the sides the bowel has come out. You don't know. So obviously the bowel is in contact with the mesh somewhere, isn't it?
So that would be my high suspicion. It will lead into bowel obstruction and complications with the mesh as well. So try to go in as early as possible. And as I'm not confident laparoscopically, I will try and do it bilateral open technique, the standard manner, which I'm more confident.
You will do it on day one itself? Or you will do it electively?
If I have the theater list, or if there is space on CPOD, obviously we'll have to check with the on-call team and colleagues as well. Or if there's not possible, I'll try to do the earliest theater space I have got available.
Okay, fine. Moving on to Qasim. Are you there, Qasim? Yes. So we just discussed what he will do. So Vishal Palmer proposed that he will take the patient on the same day or early elective day to do a bilateral open hernia repair. Do you differ from this by any way, or you are happy with the plan? You unmute yourself, please.
Yeah, I'm aware of the situation here, and I can see the patient's anxiety as he's coming back on the day first with the recurrence. So he is very apprehensive. I can see that. So I will explain the situation to the patient and explain what's the options available here. So as the laparoscopic or the TAP repair has failed, I will prefer firstly not to take the same route to repair the recurrence. So I will explain to patient that it is a known complication, though it has happened too early. So it's a technical failure, and I will take that responsibility. I will also explain to patient that it is something that is repairable or correctable. And I will explain that the next option is opening it through a virgin area or a different route that will be an open repair. I will also explain to patient that as the open surgery or open repair has this disadvantage that it will be a bigger or a larger incision. So I will prefer doing one side at a time, and I will talk to patient that which side he thinks was more symptomatic.
So you won't do bilateral open hernias together?
And I will prefer doing one side at a time.
Why is that?
As I mentioned, that the open repair has a bigger cut and it takes longer time, and also because I am dealing with a situation where there is a recurrence, and I don't. There is already a dissection done internally, and if I do a bilateral open repair externally, it will be a higher risk of post-operative pain, and if something goes wrong, then it will be a difficult situation for me to further correct it. So also it will give a confidence to the patient once the one side is healed or repaired, that I'm hoping this time will be the same.
Will be, you know how distressful it is to the patient, isn't it? So already you did one surgery which failed, and then you want to do 2 more surgeries to sort out this complication. Are you happy with that?
Yeah, I mean, this all depends on discussion with the patient, and I can explain to him that I will explain that I have a lot of experience doing an open repair, and if he thinks have a confidence in me, I'm happy to proceed. But if he thinks that he doesn't want me to proceed, then I will involve a colleague of mine and have another discussion with my colleagues, and if the patient insists, I will refer to my colleague for the repair.
Chris, can you tell me what was the cause for this recurrence in this patient? What could have happened?
Can you hear me?
Yes.
So it may depend on how the mesh has been fixed, whether it's just been, some surgeons just leave it in place without fixation. So if it's not been fixed, it may have just moved as the pneumo has been deflated. If it has been fixed either with sutures or tacks, it may have been incompletely fixed. So I suspect it's an immediate mesh movement at the end of the case.
Okay, so what are the ideal sites of placement of fixing this mesh?
So typically, I put a suture in Cooper's ligament, and then 2 further sutures superiorly either side of the inferior epigastric vessels. I'm aware
You mean in laparoscopic repair you put a suture in the Cooper's ligament down, and then you put 2 sutures on either side of inferior epigastric?
Yeah.
Laterally.
Well, one medial, one laterally.
Okay, so you put 2 stitches on the medial end of the mesh and then 1 stitch on the upper lateral aspect, you mean?
Yes.
So you don't use any tackers and stuff?
No.
Okay, so how much space you will create in front of the bladder?
So medially, I would go down to 2 centimeters below the tubercle. Is that what you're asking?
Yeah, I mean, when I say ideal mesh placement, you need to tell me how much space you dissect and how do you fix. So
yes,
in other words, what are the steps you will take to prevent this recurrence in your primary operation?
So fixation of the mesh medially at Cooper's, fixation of the superior aspects, and getting a nice flat mesh.
So do you routinely do tap or tap? What do you do?
Tap.
You do tap. Okay. So will you cross the mesh to the midline, or you will just keep it on one side? Will the mesh crosses to the midline?
Yes. So it should slightly overlap the midline.
Okay. So we had different answers so far. So Tamir told he wants to do it electively later, bilateral hernia repair. Yeah.
Yeah.
And Vishal told he want to do the same day, but he want to do an open repair. What is your plan in this case?
I think it would be reasonable to take the patient back to theatre emergently. The longer you leave it, the harder it's going to be to go back in. But at day 1, day 2, it should be, there couldn't be much adhesion,
So what are you going to do? You take the patient to theatre and then?
I'll take reopen the peritoneum. Depends how you've closed it with
You do re-laparoscopy, you mean?
Yeah.
Okay.
Yeah.
Okay.
And
then?
Assess where the mesh is. So I'd assume that I'd find a mesh rolled up. I'd probably take out that mesh, take a fresh mesh and repeat.
So you do a redo laparoscopic repair?
Yeah. You're essentially correcting a technical error. So that should be sufficient. And then you avoid the risks of having to do bilateral open or some other secondary technique.
Okay, fine. So what is the incidence of recurrence following a laparoscopic hernia repair?
An early recurrence like this, I would say, is very rare. But I think generally the long-term recurrence rate sort of between 5 to 10%.
Fine. I'm going to stop you here. Okay. So Abdullah, Mustafa, and Islam, do you have any difference of opinions? If so, you can tell, or else it's fine. I will go into the discussion. No, Islam, Abdullah, no? Fine. Right. So this is a very typical case. Yeah. Very typical case in the exam. So in the exam, you...
Yes. Hello. Sorry.
Yes, Abdullah.
Yeah. For me, what I would like to do, first of all, after making sure that the patient is fully resuscitated and is not in pain, I would like to admit this patient to the hospital and have meeting in the morning with a senior consultant who is specialized in anterior abdominal wall reconstruction.
Abdullah, this is an inguinal hernia. Why are you worried about an anterior abdominal wall reconstruction?
I mean, who is expert in hernia and discussing with the patient multiple options about either early repair or late repair, discussing with him the benefits and risks of early and late repair, and have a shared decision with the patient and with my senior colleague who is more expert in hernia than me, because I'm day one consultant and might be I have technical error. So I do believe that shared decision with me, consultant, senior consultant, and the patient for me is the best decision here.
Fine. Right. Islam, you raised your hands. You have anything different?
Yeah, thank you. I wouldn't do CT scan from the start if it's confirmed clinically, and I'll take patient if I have the capacity and like early hours of the day, I'll take the patient to theater directly, laparoscopically, open peritoneum, make a better space and fix the mesh from space of radius medially to the anterior superior iliac spine laterally. And yeah, day one or day two, you can either wait till the next morning and do it the other day, but not later, I think, because afterwards it's going to be more friable. The peritoneum will be very friable, and you'll need to do it open technique.
So you will you will create a space. You will take out the mesh and do. If the peritoneum is friable, you will take out the mesh out.
No, sorry, I said if it's the same day or the second day, I can
Do laparoscopic.
it's not friable, I'll do it laparoscopically. But after that, it's gonna be more friable and more challenging, and it will be open.
Fine. Right. So the main reason for putting this scenario to you all is to demonstrate this. So 7 of you had 7 different plans for this patient. Okay. So one wanted to do CT, other one was against doing the CT. One wanted to do on the same day, other wanted to do after like 6 weeks. Few had laparoscopy and open. One of you wanted to do one side open. So this is exactly how an exam scenario would be. There won't be any single right answer. Every one of you are right here. Every one of you are wrong here. That is how the responses are. So I can argue in a way that you are right. I can argue in a way that you are wrong. This is exactly what so whatever you say, the examiner is going to challenge you. Why? And you need to substantiate why you are doing this. This substantiation may be because of an evidence which you read, or maybe because it is your practice. You can tell this is my practice and this is what we do. Or it could be because of your competence. You can tell that I don't know that, I can do only this. So this is how you substantiate every answer. So in the exam, you will get a scenario where there is no single right answer. They are going to test a scenario which has multiple options and see how you deliver it safely. Most importantly, how you deliver. The moment, say, for example, so Islam tells me, I will do it laparoscopically, I will refix this. And if he says me that, the examiner is going to ask you immediately, how many tap repairs have you done so far? If Islam says that I have done only 2, according to me, I might communicate this to him, or I may not communicate this to him. I might think in my mind that he is doing a very unsafe procedure on a day one as a day one consultant. According to me, he is doing a harm to the patient where he already doesn't have any experience with elective repair. Now he is trying to fix a complication by himself. So at this point, if Islam had told me, if Islam had told me, yes, I have done 150 lap hernias, then I'm happy. Oh, he's an experienced surgeon. He can do that. Okay, so this is how we test you. What you would do at that point and why. So for example, Qasim told, I would do one-sided hernia repair while I won't do the other-sided hernia repair. So when you give such type of responses, you need to be quite very careful. You cannot be telling something which is very, very new Okay, so common things are common in the exam. So because, doing a bilateral open hernia repair as a day case is very, very common in most of the trust, unless it is a different practice in your trust. I don't know. So fixing this, so you need to weigh the balance with, yes, your thought process. I appreciate your thought process that you need to be very careful in this patient. You don't want to give bilateral pain to the patient. So you want to fix one side, gain some confidence, go on the other side. But at the same time, you need to understand that you are disrupting the patient's routine for almost 6 months. You do the surgery, 3 months he cannot work. You do other surgery, 3 months again he cannot work, which is going to disrupt his entire lifestyle for 7 to 8 months now. So you need to think about that. And it is very, very uncommon for someone to tell, for a bilateral hernia, I will do one side first followed by other side. Okay, of course, if the patient is coming electively and if patient has problems only on one side, yes, you fix that one side, other side you don't need to fix. That's a different thing. So here he has come back after recurrence and then that. So the take-home message till this point is every question has different responses. You need to tell what you will do as a young consultant. That's what is required. So you can tell, I have never faced this complication in my life. I want to get an opinion from my senior consultant or boss to see what I can do. So this is about the management. Leave the management. This will come. But coming on to the essential Viva techniques. So if you see these questions, it started from a very, very simple question to a very complex question. Okay, asking from what are the causes for day one recurrence, how do you fix a mesh, where do you keep a mesh? If I had time, I would have still gone further to ask what is the difference between tip and tap, what is the evidence comparing between secure strap, ProTac, and sutures, why do you want to use suture when compared? So when Chris told me that he want to suture it, okay, which many of the consultants doesn't do, we always tack it, I would have asked him, why are you using sutures and what difference it has? So these are the last level of questions. Okay, so any scenario will start from a very simple question to a very, very tough question at the end. So as long as you cross comfortably, the last two questions asked by the examiner is to give you 8 marks. Okay, if you don't know the last 2 questions, it's fine, but you need to utilize the first 3 questions to give an impression to the examiner that you are ready to become a consultant. So how do you tell that? The most important thing is what we say is express your higher order thinking in the beginning of the scenario itself. When I say higher order thinking, you need to tell how do you feel about a particular situation and what is running in your mind. That should be your first answer for every scenario you answer in this exam. So in this situation, say a day one patient coming back to me after this one, so I would tell that I am extremely worried about the situation, or I am concerned about the situation, because it is not common for a person to walk into an A&E day one following a bilateral inguinal hernia. The possibilities running in my mind are, it could be tell from common things to uncommon. It could be a recurrence. Sorry, it could be a hematoma, it could be a seroma, or it could be a mesh migration and a treatment failure, or you can even tell an early recurrence. So this is what is running in my mind. However, I can also think about it could be something like a bilateral orchitis, which is also a differential diagnosis. So higher order thinking is something where you express your higher order broad thinking rather than sticking to one thing. Okay, for example, a post-cholecystectomy patient coming back with pain. What do you think? Okay, you tell everything related to gallbladder. It could be a retained stone, it could be a bile leak, it could be a CBD injury, or it could be an injury to something. But there could be other causes. Patient could have pancreatitis, patient could have gastritis, patient could have, say, a liver abscess. So that is called as a higher order thinking. So you need to tell everything possible in this patient. So in this patient, the common things are hematoma, seroma, recurrence. However, other things in my mind are he could have an orchitis, okay, or he could have, say, a wind trapped in the scrotum secondary to a hernia repair. So this is how your first answer to any scenario should be. So the examiner should feel comfortable questioning you, looking at how you answer your first question. Okay, so we call it as a landing sentence or whatever. So that should tell your higher order thinking. The second important thing is, as I told, time management is very, very important in this exam. So you don't have any room to waste even 2 or 3 seconds. So many of you had the habit of paraphrasing the question, whatever I asked. So I told a patient coming on day 1 with bilateral recurrence, what you will do. Oh, this is a patient who's coming back on day 1, having the surgery yesterday with the bilateral groin swelling. What is running in my mind are. So you have already wasted 10 seconds for nothing. Yeah. So your answer should be straight to the point. So what you will do, I am concerned about the situation. These are the things running in my mind. I would like to get a big good history from the patient on what happened. No one told me about what happened to this patient. So you should have asked if he did some strenuous exercise in the middle of the night, or did he have a violent cough in the middle of the night, or he fell down somewhere. You don't know. Okay. If those things are there, obviously with the history only, you can think that it could be some vessel which is bleeding, or it could be a recurrence or something. No one told about that particular history of what you want to get from the patient. So that is something which is expected from you in this exam. So what they see is, how you need to answer is, if this patient is standing in front of you, you just imagine, you go back to your clinical scenario and you tell whatever you would do as a consultant. Think that you are a consultant and there is no one above you, and you have to make decision at that point. So that is how you need to think to answer. Okay. And common things are common. Never go into rare of the rare diagnosis and rare of the rare practices. That's very, very important. Okay. And it is always safe to tell what you would do. Never list options. So what you will do, I will do. My practice is to do this. You cannot tell the options are, I can do open repair, I can do laparoscopic repair, and this. It's not like that. You need to do. So in this case, what I would have done, okay, what I would have done is exactly like what Islam and Chris told. Okay, my major concern in this patient is, of course, there is a surgical failure. The mesh has slipped some way or displaced or something, and the bowel has come out. Okay, now already the bowel is in contact with the mesh, yeah, which is a synthetic mesh. Of course, if I had placed a biological mesh or something, I would be a little more comfortable. I would not bother much, and I would still do an open repair. But it is a synthetic mesh, and the bowel is in contact with the synthetic mesh. So I would re-laparoscope on the same day or the next day. I will go in. I need to assess what has actually happened. Yeah, what has actually happened. I open up the peritoneum. If it is TAP. If it is TEP, I will still go in directly. Actually, I will do if it is a TEP repair, which I have already done, I will go TAP. That's my practice. I will go TAP, create the peritoneal flap, see what has happened, try to see if you can refix the mesh, or at least if I am not refixing the mesh, I will remove the mesh. I will remove the mesh and then do an open repair. This is what I would have done. Yeah. And like someone told me, I will try to add evidences wherever possible. Okay. So for example, simple things like Tamir told me that I will resuscitate the patient based on CCRIS protocol. Okay. So resuscitating instead of telling I will resuscitate the patient, you will be getting only 6 marks out of 8. If you are told I will resuscitate the patient based on the CCRIS protocol, you will get 7 marks. Okay. So if you have told that I will assess the patient based on the CRIS protocol, making sure patient is hemodynamically stable, you will get 8 marks. For the same right answer, the marks given are different. Okay, so this is what you need to learn in the next 3 or 4 months before the exam, to unlearn whatever you have been doing and learn what is necessary for this exam. Okay, any questions so far? Yes, Tamir, tell me.
No, just a question to Chris regarding the sutures and the tacks. Why it's better to suture rather than tacks?
You tell me.
I'm not sure. Well, I used to do that, to put the tacks, not sutures. Yeah.
Okay, so, Chris, you tell me. Why do you want to suture?
Because that's my practice. Yeah, I think it's good practice for suturing, but yeah, I don't have an evidence for it. It's just.
Mustafa?
So in our practice, we used to do first tackering, then we switched to suturing because we observed that these patients experience less pain by doing sutures.
Absolutely, it's mainly for pain. So the whole the main difference between a lap hernia and the open hernia repair is mainly pain. Yeah. So the recurrence rates are similar, complication rates are, everything is similar. In fact, laparoscopic repair in most of the consultant's hand takes little more longer time than the open repair. However, the biggest difference is the pain. Okay. So the pain is much less with laparoscopic hernia repair. Okay. We are trying to reduce still more. The only reason for pain in a laparoscopic hernia repair at this moment with most of our usual practice is, one, obviously the port sites, and second thing is because of the tackers. So when we push this tackers, that's why especially with the inguinal hernias, we try to fix as minimal as possible. Most important fixations are the medial aspects rather than the lateral aspects. And, especially when you tacker on the abdominal wall, many people have the habit of pressing the abdominal wall to tacker, which is not good, because this tacker will go deep into the abdominal wall and which can cause pain. One. So we tend not to press too much. Similarly, more and more spaces you fix, more chances of these tackers going into the subcutaneous plane causing pain. So the suturing is one thing which prevents this pain. Again, if you see the consultants who practice the suturing, they don't fix it tight. It is just anchoring. You just make a suture and tie it loose to hold the mesh. That's the whole purpose. It's not, you don't need to be making it tight. So that's definitely a good evidence. Means I don't know if there is a randomized trial or something which has been done comparing this and that, but definitely that's the whole ideology behind suturing. Similarly, by using the tackers, again, most of us have moved towards absorbable tackers than from the usual Pro-Tacks which we use. So again, the reason why we had moved to absorbable tackers is again for pain. Yeah. Another common question which you can encounter in the exam is patient 3 years down the line or 3 months down the line, patient presenting with groin pain following hernia. So management of inguinodynia is a very, very common scenario in the exam, and they can lead to different aspects. One, it could lead to a recurrence. One, it could go into chronic orchitis. It can lead to, osteomyelitis of the pubic tubercle. It can lead to, say, a mesh infection. So anything. Yeah, that's another common scenario in the exam. Yeah, Qasim, tell me. Unmute yourself, Qasim.
I just wanted to add one point that it's now evidence-based proven thing that there is a trend from penetratable fixing devices to non-penetratable. So there is a trend now from tackers to glue fixation.
Absolutely.
And it has shown benefits of less pain and less immediate post-operative complications like hematoma and seromas.
Absolutely. And in fact, I use a lot of glues. So in fact, especially with inguinal hernias, where we just rely on placing the mesh on the peritoneal reflection down, when we have glues, you can just put all the drops. So you can even you can fix inferiorly with inguinal hernias actually. So in that way, glue is much superior, I would say. But still, I am not very convinced about the medial fixation yet. So still, I use tackers for the medial fixation on the pubic tubercle and stuff. Yeah, good. So if you don't have questions, let's move to a different scenario, analyzing a different aspect. So who wants to take this up? Qasim, you want to? Right, Qasim. Right. So you are again, it's consider it as a 10-minute scenario, okay? Or 5 minutes. This kind of scenarios will come in critical care for you, okay? So you are a consultant on call, and you have a 64 years old male patient, okay, who had come to A&E with abdominal pain. Clinically, he had peritonitis. You did a CT scan which showed pneumoperitoneum. You took the patient to theater, you did a laparotomy, and you found that there's a small bowel perforation, but there is extensive metastatic deposits. Okay. You don't know what is a primary, and you didn't want to disturb anything. You decided not to do anything. You just primarily closed the rent with an omental patch. You came out. Patient is extubated. So you're going and explaining the patient's next of kin that this has happened. The next of kin is telling you not to disclose this information to patient because patient is already suffering from severe depression and he would not cope up with this emotional damage which you would cause by disclosing this information. what will you do?
I'm aware of the complexity of the situation here. On one side, patient has all the right to know what's happening with him. And on the other hand, I'm also aware of the impact of disclosing this news to the patient, as explained by the next of kin. So I explained to the next of the kin first that this is a matter that is going to impact the life of the patient. And this is something that we, unless we disclose, we will be in a position or unable to do any further investigations or treatment. So it is a situation where it is mandatory to explain the true pathology or the findings to the patient, so that we can have a discussion about what we can do next. So I will explain to next of kin. Then I will have a mini MDT in the morning with my colleagues, explaining the situation that I have come across with this patient yesterday or last night. And I'm planning that I have taken biopsies. I've sent the biopsies to for histopathology. And I'm planning at least to find the primary, because it's going to change the management. If it is something...
No, so that is not the crux of the disc. So you have deviated completely. So we are not worried about the biopsy and stuff here. So breaking the bad. So you had found a metastatic disease. Whatever it's a biopsy, whatever is the treatment, he's not going to live for more than 6 months. Okay. The son says, don't tell my dad. And you know that the patient's background history, a patient has severe depression, etc., etc. How are you going to deal this? Yes, you told the patient's son that you need to inform the patient, and then what happens?
Yeah, I will involve the palliative team in this situation, and also involve the mainly the palliative team. Also, I will involve, and I will get their help to explain to patient. I will also involve the psychiatric team as well in the immediate post-operative recovery period to help stabilizing patient's mental condition. I will hold this news to break immediately after operation, because I know it's not going to change my management, but I will focus more on patient's mental health and mental status. And I will wait, in a week time or so, if I think the patient has stabilized, I will actually plan to bring him back in my clinic and then reserve this news
now,
for a later date.
How can you discharge a patient? Patient has capacity. Patient has consented for this procedure. And what are you going to write in the discharge summary? What are you going to tell the patient when he goes home? Are you going to tell that everything is fine?
No, I'm not going to lie or hide the facts. It's just I'm also respecting and keeping into consideration what the concern the family and the son has raised. So to me, I think that is also a very important aspect to consider.
So, okay, so in the same evening, so you have spoken to the patient's next of kin. You have told that, no, I need to speak to the patient, and you are in a double mind. You are going to see this patient. The patient is calling you, doctor, have you sorted out my problem? What are you going to tell him? I am your patient. I am your patient. Tell me.
Yes, Mr. Mani, we did your operation, and that was the right call to do. We found a hole in your bowel, and that was causing a lot of contamination, and I have fixed that hole. But at the same time, I would like to tell you that was not the only problem we found. I have found disease in your rest of the abdomen that looks very serious to me. And it could be a cancer or a malignancy. So I have taken some tissue biopsies, and we are waiting for the result of that.
So now you are contradicting your own statement now. So you told that you don't want to tell until for a week. Now you have disclosed everything immediately.
Yes, yeah, you're right here.
Yeah. So how you would have managed now? So this is what you would have done, or you would have done something different now?
I would have done the second way I just expressed.
So you have gone and told openly to the patient this has happened.
Yeah.
Okay, imagine when you start telling the patient tells you that, doctor, I don't want to hear anything. Whatever it is, you speak to my next of kin. If he says that, what you would do?
Then I will not keep explaining the situation. I will actually call the next of kin and explain the true facts and findings that I found.
So what is the harm? Say, for example, why don't you say this patient, whatever it is, patient is going to die in 3 or 4 months. Yeah, looking at the metastatic. Say you found even a cancer. Say you found a big rectosigmoid cancer with metastasis with liver mets. Patient is going to die. What is the harm in going with the next of kin's wish of not disclosing this information to the patient?
I think every patient, I believe every patient has the right to know what they are.
Is it just your belief or what?
It is a mandatory fact, actually, that I'm bound to tell the patient what they are suffering from. And every patient has the right to decide after giving the options, the treatment options, what they want to do.
What are the key principles? What are the key ethical principles? Okay, as a clinician, in delivering any service to the patient, what are the 3 important principles, ethical principles?
Yeah, so the diagnosis, the treatment options, the risk and benefits of each option, and what if. I mean, these are the main ones. I mean, the main diagnosis, the treatment options, and the risks and benefits of each option.
So what is meant by preserving the autonomy of the patient? What do you understand by the term?
Sorry, I'm not very sure about.
Okay.
I think it is basically the patient is the main center or the focus of the whole decision.
Absolutely, absolutely. Chris, what is your opinion, Chris?
Yeah, so I think this seems right to talk to the patient. I don't think you can justify withholding that information. It would be reasonable you could start that conversation with the patient by saying, I give them some of the information and say, I have got some more information. Your son has already told me that he's worried about you receiving this information. Would you like me to tell you all of the information? Some of that might be bad information. So you could give a sort of warning shot. The ethical principles of the other one is consent, I think, isn't it? If this patient's consented to an operation, you've performed it, I think you are duty bound to inform them of your findings unless they've asked you not to, or they've decided they don't want.
Right. So this is, you will, in your exam, at least you'll have 1 or 2 scenarios which is like this, which involves ethics, medical ethics. Okay. So what you would do, as you all rightly mentioned, you need to, the key principles is the autonomy of the patient. Every patient has the right to know what he is undergoing, and he is the prime person who can make decision for themselves unless they have given and signed power of attorney to someone, or he lacks capacity due to some reason and the court is involved. Without that, every decision has to be made by the patient, not the next of kin. Okay, and you have to act based on the best interest of the patient. Okay, and you should do in a way that you don't do any harm to the patient. So these are the key principles. Okay, so here how I would have approached this, I would acknowledge the son's wish of not telling the patient. I would tell that, yes, you are absolutely right, and I can completely understand this. However, so he is the patient, and the basic ethical principle is anyone's autonomy needs to be preserved. So he needs to know what is happening in him, but we will make sure that we will disclose this information in a very gradual manner, in a way that it doesn't affect him. We will make sure that we will have adequate support team. We have, say, a psychologist with us who can come in, and we can gradually tell the information to your dad so that he understands. If at all, if he says that he doesn't want to hear this, and if he tells me to discuss with you for further plans, I'm happy to discuss with you, or else every information needs to be spoken to the patient. Okay, and we will, I know it's a difficult situation for you guys. You can arrange some family support, you can arrange some family counseling and stuff for the family, but to the patient, you need to tell all these things. Okay, so this is how an ethical situation is managed. Similarly, you will have another way of ethical questions or clinical governance question which you could get in the exams is someone doing some mistake or some mistake you had identified. For example, simple things like say you have say you find your colleague who is a very close friend of you who is not following the essential WHO checklist while doing the operation. You are finding this, what you would do. Okay, this is a very, very common question. Or say you have a situation where someone is not scrubbing properly in the thing. You are seeing it. Okay, it could be your colleague, it could be your senior colleague, or it could be a registrar, or how you will manage. So this is a very, very common scenario in the exam. So again, in the exam, certain catchphrases are very, very important. So in this scenario, if you are told that use the keywords like ethical principles, medical ethics, autonomy, non-maleficence, beneficence, if you use those words, you will score 8. You told the same thing, but you didn't use these catchphrases. Same thing when you have situations like this, say something is going wrong, what you need to do, you need to start the situation like, I am unhappy with the situation, my priority is patient safety. Okay, this is how you need to start. Then you tell how you want to proceed. So I will go and speak to the person, whoever does this, and you will express your unhappiness in his behavior, and you would tell this is what is happening. And I will go in a very gentle manner to make him understand what mistake he is doing and see how he behaves. If he still doesn't behave, you need to know where to escalate what problems. If it is a registrar who is doing a problems, you tell him. If it doesn't work, you can go and tell his supervisor, or you can tell his TPD. Okay, if your consultant colleague is doing a problem, you can speak to clinical director. If you have a clinical director who is doing a problem, you can go to chief executive or a medical director. Okay, so this is how you need to escalate these problems. Okay, another area of problems and the problem related questions which you would expect is something going wrong and how you do an datex and stuff. Okay, say for example, you did a scenario, or let me ask someone who wants to go next. Chris, you want to do next? Yeah. Okay, Chris, so imagine you are doing a lap appendicectomy. Okay, you are starting this procedure, and you are put in the scope, you're starting to do the procedure, and then a scrub nurse comes in and tells you that, oh doctor, sorry, this scope sterilization got expired 4 days back. Unfortunately, we are sorry. The sterilization expiry is gone. The staff nurse is telling you. How will you respond to the situation?
Okay. And has the scope already been put inside the patient?
Yes.
So I mean, my first priority is to remove the scope from the field of the operation. My initial thoughts are that if we've started the operation, it's probably not in the patient's interest for us to abandon halfway through, but my priority is making sure he's safe.
Patient is very fine.
Yeah.
You have put in the scope, you have taken out the scope.
Yeah.
What happens?
So we're going to need a new scope. It's the immediate thing I would ask for. If the patient's not already had a shot of intravenous antibiotics on induction, I'd ask the anaesthetist to give that. I think if a new scope is available, then I'd proceed and complete the operation. And then after the operation, I'll also go and have a conversation with that patient about what has happened. Due to your candor, I'd want to put in a datex and understand how the situation's come about. I think those would be my first steps.
What is your next step?
So obviously, yeah, if the patient's woken up from the anaesthetic, say I'll go and have that conversation, explain what's gone on, apologise, I think I'd explain the main risk really is that of an increased risk of infection. We took steps to mitigate that. We may continue antibiotics. It depends a bit on the clinical scenario, but
what else you're going to do? So this, yes, you have, from the patient's perspective, you took up the accountability of this thing. You took up the responsibility. You were very transparent, telling the information to the patient. What else? What next? You put a date text and then?
Yeah, I mean, I'd want to investigate how this could have happened, because there should be processes. So the datex will start that process, but I'd proactively reach out to the tester in charge of theatres.
So will you go and tell the patient, or you will ask the staff nurse to go and tell the patient? Because it's their mistake, isn't it? Why do you want to bother?
I would tell the patient myself. I mean, I've done the operation, so the patient's my responsibility. The theatre staff involved may wish to document their involvement in the notes, should it come to anything medical legally, but I think it'd be my responsibility to tell the patient.
Fine. So, so this patient goes home without any problems. Okay, comes back within a week with fever. Okay, and she's blaming you that the scope has caused the problems. How are you going to deal with the situation? What are you going to tell the patient?
Okay. Am I seeing the patient in A&E? Is this
yes. So before that, so when you perform this duty of candor, imagine I am the patient. You can tell me what you're going to tell me.
Okay. I mean, I'd usually have a bit. I'd start by introducing myself, discussing. So we found appendicitis. We've treated that. I'd explain that there was a mistake in the preparation of the sterilization process. That meant that a camera that shouldn't have been put inside your abdomen was put inside your abdomen. There's a risk that means that it may not have been as sterile as it should be, and therefore the increased risk of infection. I'd explain the steps we've taken to mitigate that. And
so doctor, what's the chance of me having this infection? So you mean that it is a dirty scope which you had put into my tummy?
No, it's still been sterilized, but it's expired beyond the time at which we would expect it to have been used by. So it may not have introduced extra risks to you, but it could have. So for that reason, we apologize, and these are things that I've done to try and.
So how is my management going to be different from if you had used a sterile scope?
It may not be any different, but there's a small increased risk of infection using out-of-date instruments.
So how did this happen, doctor? Why is that the mistake happened on me?
The short answer is I don't know, because there are processes in place that should stop this. So part of my job is to find out how this happened. There'll be an internal investigation, and I'll communicate the results of that to you. I'd be happy to see you back in clinic with the results of that to talk through that if you like.
Fine. So I'm going to stop you here. Okay. So this is again another clinical scenario. Okay. It's just a clinical problem, very simple problem, but we don't know, when I say we don't know, you did whatever everyone would have done. I would have done the same, but for this exam, we expect certain key phrases from you. Okay. So when such thing happens, you need to tell, I will stop the procedure first of all. Okay. So when the staff tells me that I will stop the procedure, take out the scope, ask for a fresh scope, I will communicate to the anesthetist. I will first make sure patient is fine. I will complete this procedure first of all. The next important thing is if there is a duty of candor. But before the duty of candor, you would have done a sign out. Yeah. So because you need to tell in a chronological order. So during the sign out of the patient, I would raise this concern, and I will tell the staff nurse, whoever is in charge, to put an incident report or a DATEX. Okay, you need to use these words: incident report or a serious incident or a DATEX. Then I will go and perform the duty of candor. Okay, during the duty of candor, again, the key phrases which they ask is, I would take the responsibility of the situation. In this situation, because you are not directly related to this, because sometimes if the patient asks you certain questions like how long the sterilization lasts for, okay, for example, when was it sterilized? If they ask you, if you don't know, you might look like, you know, you don't know. The patient might think that, oh, you don't know even this. Okay, so it is always ideal when you don't know the 100% reason of what error has happened, or if someone else is involved, it is always better to take the other person also with you, so they can answer those related questions. The patient will straight away ask, when was it sterilized? So normally when it is sterilized and kept in a box, how did it even come here? You don't know those answers. Okay, so you need to have that person. So you need to use these words like, I would be transparent in whatever has happened, the transparency. I would take up the accountability of the situation, again those words, and I will tell very openly whatever has happened, and I will tell what is going to be the follow-up. After this, again, you need to tell that I will not stop here. Okay, so whatever you have told, you will still pass the scenario. But in order to score 8, you will tell these words, and then you will tell, I'll go back to theater, I will look at the DATEX, okay, and I will make sure, I will lead the situation, and I will perform a root cause analysis of whatever has happened, what mistake has happened. Okay, and I will make sure if there is any checklist which was not done, because whatever it is, you know, in the WHO checklist, yeah, during the timeout, yeah, the one of the question to the staff nurse is, are you happy with the instruments? Okay, so there is definitely a breach in this question whichever has happened here. So you need to tell that the WHO checklist was not followed properly in this case. So I will make this as an input, and in my future cases, I will make sure that this is something which I will look into. And most importantly, as you rightly mentioned, you are going to investigate this and you are going to communicate this to the patient. That's very, very, that completes the duty of candor. You need to tell what investigation you have done and what has happened. Okay, so this is how, again, these kind of ethical questions needs to be answered. Yeah. Yes, Tamir, do you have any questions?
Yeah, you know, similar like this, you know, the burn from the diathermy. Every
Absolutely.
time the clinical lead in theater, she will do the DATEX or he will do the DATEX and come back without any benefit, like saying we don't know what happened. Could be this, could be this, could be this, and this is what happened.
Yeah, so that's very true. So this one, no one knows how it has happened. It is a mistake. It is a human error which has happened. Obviously, there you overlooked certain things which led to this. Okay, but it is a mistake. And if the patient comes back within a week telling that I'm having a fever and abdominal pain, you cannot neglect the reason of this scope being used. You need to tell it could be, but you need to accept and you have to go ahead. It can lead to, and because the way you communicate to the patient matters a lot, which makes the patient whether to sue you or you to accept your explanation. It's very, very important. Okay, let me ask a similar scenario to someone. So who wants to go next? Anyone apart from Qasim, Tamir, and Chris? Anyone? No? Vishal, you want to take? Okay, Mohammed Osman. You there, Mohammed?
Yes, I'm here. Yeah.
You want to switch on your camera if you want, or it's okay if you don't want. That's fine. Okay, Mohammed. Now it's another interesting scenario. Imagine you had 4 patients, 4 open inguinal hernias in your elective list. Okay.
Yeah.
And you had done the first patient, went very well. Okay. And this patient goes back to the day treatment center to go home. Okay. And in the day treatment center, when the patient goes home, they are giving him a patient information leaflet on post-cholecystectomy care. This patient is given a post-cholecystectomy care paper to the patient. Okay, this patient goes home with a post-cholecystectomy care, and on the top of it, patient's discharge summary, you had printed on a paper on the backside of which you have all the 4 patients whom you are planning to operate with all the details mistakenly. And the patient is writing to you next day, putting a big pulse complaint, telling that I had the hernia operation. However, I have given a leaflet about cholecystectomy, and I have the discharge summary. On the back of the discharge summary, I can see 4 patients who had operation along with me with their name, age, date, and the surgery. This is a big pulse complaint, and this pulse complaint has been forwarded to you. What are you going to do?
Yes, I will speak to the patient, and I will apologize to him. This should have never happened. And first of all, there are 2 things which needs to be addressed to, and obviously, I'm going to get some more information about why this has happened. First of all, I would want to know what did the leaflet say about cholecystectomy, which is a completely wrong thing, and he should have had a leaflet post-operative hernia repair. So I will be concerned, and my concerns would be that I will actually ask him how he's feeling, and I mean, he's had a long, he's had a wrong leaflet about a different operation which is addressed to differently. So has he taken any wrong medication? Has he taken? I'll be concerned about patient safety first. So I will ask about how he's feeling.
You have not come to the answer yet. Now only you're starting your answer. You've wasted 2 minutes already.
Yeah,
that's fine. Tell me now.
So,
so patient is doing fine. So you are calling the patient. I'm telling that I have no problems with the surgery. Okay.
Yeah.
But I'm extremely concerned that you have given me the information about 4 patients, and I have been given this one, such a careless care which I had received.
I'm really sorry about that. Making sure that you're doing all right at the moment. I'm going to address this, and it would be appropriate to have you seen as soon as possible.
Why do you want to see the patient when patient is doing fine?
I mean, it's got a it's got a wrong leaflet.
Yeah, you can tell the patient to tear and throw it away. It's just a patient information leaflet which you can get in any of the NHS website, isn't it? You can tell that this is the error which has happened. You should have received a hernia leaflet. However, you received a cholecystectomy leaflet. Please throw it away.
The reason why I'm to see him is, I mean, I need to have that. There's a breach in patient confidentiality about having other people's information. I would say, and this is certainly a serious incident with a breach in confidentiality with other patients' information being. So I would want to have that paper back.
Very good. So you got the paper back. You destroyed it. Now what next?
I will lead this to. I will make sure the patient has got the appropriate leaflet and appropriate follow-up plan. I will also provide him with further information about patient liaison services. If he's got any problems or any questions he wants to further raise, then he can contact them. I will also make an arrangement to have a later on follow-up to see how he was doing from his surgery.
That's fine. So those things are fine. Is that all?
Yeah.
Anything else?
I would want to lead this further towards the incident report, the root cause analysis of what has happened and why this has happened. Is a steep learning curve. Where was the problem? Was the patient...
That's fine. So you do all these things like what we discussed before. What else? Anything else you are still missing? Anyone else? Yes, Qasim, you want to add anything to this?
Yes, the 4 patients whose information has been sent to this patient, they have the right to know that their information or their confidentiality is breached. So I will write a letter to all those 4 patients telling about this incident, apologizing about this breach in the information, and also explaining what actions I have taken to prevent this happening in future.
Absolutely. Yeah. So again, that's the thing. So here again, you need to tell that I'm extremely concerned about the situation in the complaint. This is a 5-minute scenario in the exam. Yeah, whatever we are discussing now, we need to discuss in 5 minutes, which we are discussing for 15-20 minutes. So I am concerned about the situation, which is a serious incident. 2 issues. One is a wrong information given to the patient. Second is a breach in the patient confidentiality. Okay. My priority here is, first of all, I'll speak to the patient, make sure patient is doing well from the surgery. That is your priority. The second thing which I want to tell is I need to apologize that a wrong information has been given, and also need to apologize that the paper used to print your discharge summary was mistakenly kept in a different paper which had the patient information. So I will apologize, and I will tell the patient to send back at least the discharge summary with the patient information. We don't need to get back that leaflet of the lab colleague stuff. Okay, you tell that you will forward an email about the post hernia follow-up. However, you need to either come and give it back to us directly, the paper which has the patient information, or you can post it to us, or if it is anywhere close by, we can arrange collecting it from you. Okay, and you need to tell that once it comes, we are going to destroy this paper because there is a serious breach in the confidentiality patient information. And then next step is you need to call every patient. In fact, it's better to speak to them rather than sending a letter. Call everyone, tell that this has happened, you apologize for the situation, and make sure they're also doing fine. Yeah. And you tell that we are seriously investigating this issue and we will get back to you with a report. Okay. So this is how you manage this situation. Any questions from others? No? Right. Okay, let us move on to a different scenario. Imagine it's a long clinical case, 20-minute case. Okay. So who wants to take this up now? Anyone? Okay, Abdullah Mustafa.
Yes.
Yes, Abdullah. So, Abdullah, imagine you are the consultant on call and you're doing a general surgery clinic, and you have a 46-year-old male who is coming to your clinic referred by the GP with history of on and off bleeding PR and weight loss. Okay. I am your patient. You can get history from me.
Good afternoon. My name is Abdullah. I'm one of the surgical doctors looking after you today. Nice to meet you, Mr. Mann. Is that okay to ask you a couple of questions?
Of course, doctor.
Yes. Please, could you tell me, please, why you are here in the hospital today?
So, doctor, you know, I went to my GP because I've been having on and off blood in my stools. And of late, I also noticed that I think I had lost some weight as well. I went to my GP, he did some blood tests, and he asked me to go and see you.
Okay. So, sorry to hear that. I would like to ask you about any generalized weakness recently, or you mentioned loss of weight. Could you tell me actually how much weight you lost in that?
I think I had lost close to 4 kilograms in the last 2 months.
Okay. If there is any change of your bowel habits in regards to diarrhea, constipation?
No, I'm always constipated, doctor. I'm always constipated, but of late I do get, some loose stools.
If there is any associated abdominal pain?
Now and then I do get cramps, but it's been there for many, many years now.
Would like to ask you about any family history of bowel cancer.
No, doctor.
In regards to your social history, do you smoke or drink?
I am occasionally I do smoke 2 or 3 cigarettes a day, and I drink half a bottle of wine every day.
Any comorbidities, like diabetes, hypertension, or kidney disease?
Nothing, doctor, nothing.
My last question is about any previous camera tests done for you or surgery to the colon.
Nothing, doctor.
Nothing. Okay, thank you.
Fine. Good. So this is before I move on. Okay, so this is how a long case in your exam will start. Okay, a very brief, small question you will be getting, and you will have an actor. Okay, actor there from whom you need to question and obtain history. So in this 20-minute scenario, you should not take more than 3.5 to 4 minutes to get information from the patient. Okay, and you need to have at least 15 to 16 minutes for your discussion. Okay, right, let's move on. Abdullah.
Yes.
Now, so what do you think?
After ensuring that I take full detailed history of the patient, I would like to examine the patient general condition to make sure that he's not anemic, as well as I would like to examine his abdomen, looking for organomegaly or abdominal mass. Would like
So
also.
What is your provisional diagnosis running in your mind?
My professional diagnosis is number one, cancer colon, diverticular disease, angiodysplasia, colonic polyps, inflammatory bowel disease, which is, I think, is rare in this age. However, it's one of my differential diagnoses.
Okay, so what would you like to do now?
After taking a history full examination, would like to examine him properly, especially PR examination, to exclude any anal pathology or
Rectal examination is normal.
Is normal. I would like to assess him for by basic blood tests in the form of 4 blood pictures for anemia, kidney functions, renal functions. I would like to, in the first instance, to ask for colonoscopy. If he is fit for colonoscopy, if he is not fit for colonoscopy, I would like to ask for CT scan pneumocolon or CT scan with contrast.
So when you did your blood test, would you like to know the blood test before you ask for colonoscopy?
Yes, I would like to know. However, colonoscopy is the cornerstone in investigation before.
So you do the blood test, and in the blood test, you see that the patient's hemoglobin is 86. Okay.
Yes.
Platelets is 44.
Yes.
WBC count is 3.1.
Yes.
INR is 2.2.
Yes.
LFTs are slightly deranged.
Okay.
Are you happy to proceed with colonoscopy?
No, I think I missed taking a full detailed history about any blood thinner medication.
Patient is not on any blood thinning medication. Okay. You did ask about the comorbidities. Patient doesn't have anything.
I would like definitely to correct his INR to optimize it at least below 1.5 before proceeding to colonoscopy, because I might take it will not be diagnostic colonoscopy. It might also be followed by biopsies, and I think optimization of his condition is very important here, especially the INR.
Okay, so why do you think this patient's INR was so deranged, 2.1?
Liver, definitely this patient has, if he has no comorbidities and his INR is deranged, I think I start to think of liver problem, might be liver metastasis, might be early liver disease, undiagnosed hepatitis B or C. This is the only things I'm thinking of it.
Okay, so how are you going to correct this INR before colonoscopy?
I would like to liaise with my hematology consultant colleague about the reason why the patient has high INR, and definitely I would like to ask for advice from the hematology team to correct the INR.
Okay, so imagine the hematologist has given you some information and you do a colonoscopy.
Yes.
Colonoscopy is normal. Are you happy with the platelets now? Platelets 44. Are you happy for a colonoscopy?
Yes, based on the guidelines and evidence-based proceeding to 50,000 of platelets, I can still proceed to do colonoscopy.
So why do you want to do a colonoscopy in this patient? What are you looking for?
Intraluminal investigations or luminal investigations has a very high sensitivity rate as per literature of almost 95 to 98% in diagnosis of any intraluminal pathology, which is my concern is intraluminal pathology.
So do you think if a patient has, so you thought that the patient's thrombocytopenia and low platelets and INR is probably because of liver mets?
I'm not quite sure. However, I'm still want to. I cannot exclude any bowel cancer, especially if the patient has loss of weight and recent deranged liver enzymes and deranged INR. I still have concern of malignancy, and colonoscopy will be my first line of diagnosis, and CT scan abdomen as well.
So you want to do colonoscopy first or CT scan first?
No, I would like to do, if the patient is fit, I would like to do colonoscopy, definitely, because...
So you do a colonoscopy and you see plenty of rectal varices, and you ended up having a massive bleed by doing colonoscopy. What are you going to do now?
So rectal varices, I'm not familiar actually with rectal varices. However, you mentioned is complicated by massive bleeding.
Yes.
If the patient is, if the procedure complicated by massive bleeding is, I would like to first of all to resuscitate the patients, to make the patient is fully resuscitated, to activate major transfusion protocol, liaise with ICU team and the anesthesia team to make sure the patient is fully resuscitated.
Why do you think this patient has rectal varices?
Rectal varices means some sort of obstruction of flow of venous system to this area. I don't know. I think now the CT scan might help here. CT angio might help here to detect why this patient have rectal varices.
So what does the CT angio will tell you?
The CT angio definitely will tell me, number one, about this abnormal vasculature, which is diagnosed by colonoscopy, as well as if there is any bleeding area can be treated by CT angio in case of complication of colonoscopy, of massive bleeding after colonoscopy.
So if it is, when I say varices, obviously, you know, the varices is a venous bleeding and not an arterial bleeding. Yeah.
Yes.
So you won't be seeing an active blush in an angiogram. Of course, you might have pooling of contrast, but still you cannot do an embolization or anything for a variceal bleeding, isn't it?
Yes.
Would you like to correlate with the blood test and the findings now and come to a different diagnosis which you are not thinking at all?
Yes, I might think now of some sort of portal hypertension or some sort of liver failure related to liver disease or active or acute liver disease or chronic proceeded to acute liver disease.
Why acute liver disease should have this problem? Do you think an acute liver disease patient should have massive, they'll have high jaundice, yeah, and they might be encephalopathic, yeah? This patient is walking into your clinic.
Yes.
Yeah. So how can you identify whether patient has chronic liver disease or not now?
chronic liver disease, I would like to assess his complete liver functions,
Which you have
including
done. As I told, liver function tests are deranged.
now this is now the rule of abdominal ultrasound or CT scan. Would like also to do OGD evidence available to exclude esophageal varices. Especially, I have diagnosed the patient with rectal varices. I might also faced with.
Fine. So what do you see here? This is the CT scan of this patient.
So this is the CT scan of the patient. So what I can see actually the spleen. Number one, I can see enlarged spleen. I can see also the spleen. It seems to be like infarcted or there is rupture. Is this rupture spleen? Is I'm not quite sure about the pictures. And also stomach. I can see. Yes, I can see thickening on the wall of the stomach. I'm not quite sure about the image, and I would like to discuss it with my GI.
So what was your purpose of doing this CT scan? What was your purpose?
The purpose is to detect the cause of such bleeding.
And you also had a suspicion whether the patient could have had a liver disease, isn't it? But you never commented about the liver. How does the liver look?
The liver look shrinks to me a little bit, as well as only shrinks of the liver I can see. I cannot see anything abnormal in the liver, to my knowledge.
What are the signs of cirrhosis or chronic liver disease you will see in a CT scan? How do you know what findings you see in a CT scan will make you think that patient has a chronic liver disease?
Yes, as I mentioned, the shrinkage of liver. This is the only things I know. I'm not quite sure about any other finding.
Okay, so you are discussing with the radiologist. I am the radiologist. I'm telling that patient has a shrunken liver with a nodular surface. There is a splenomegaly. There are some periportal collaterals. There are some mesenteric varices, and there is some pooling of contrast in the rectal varices, secondary to whatever is the injury you had made. So how are you going to stop this bleeding now from the rectal varices?
In rectal varices, actually, I don't have too much experience in management of rectal varices. However, if I am the consultant in charge, I would like to assist with anesthesia on call, ICU team, hematology team, and I would like to take this patient to theater to do backing and compression to stop the bleeding by examination under anesthesia and do proper backing to the anorectal area.
Okay, let me move on to who wants to continue this scenario. Anyone? Tamir Mohammed. I will come back to you, Abdullah. Okay, Tamir Mohammed, you can continue from here. So this is a CT scan. This is a rectal varices which is bleeding.
Yeah, I mean, is it continuously bleeding? Is the patient in shock?
Patient is hypotensive.
Hypotensive. So if there is a rule for a kind of endoscopic injection, will be fine. If it is not, then he needs EUA and try to ligate the bleeding vessels.
Okay. Anyone else? So you go there, you put the patient under EUA, you see chunks and chunks of vessels, tortuous vessels. Wherever you're taking bite, it's just profusely bleeding. What do you think is the reason for bleeding, which is not stopping here?
Obviously, rectal varices.
What's the reason?
increase pressure somewhere. There is
One is
increased
portal. Of
pressure.
course, there is a portal hypertension, which is adding
Yeah.
what else?
The hematological derangement as well.
Yes,
the high
coagulopathy. Yes, portal hypertension and coagulopathy. Unless you correct these two things, whatever you do down, it's not going to settle at all, isn't it? So how are you going to correct the coagulopathy? Of course, correcting the coagulopathy, everyone knows. Give platelets, give FFP, do whatever. How are you going to correct the portal hypertension here?
Might be TIPS, one of the options here, if the intervention radiology is available.
Before TIPS, will you straight away jump into TIPS? Say you have an esophageal varicose bleeding. When will you do TIPS, Abdullah?
In case
when I do TIPS, usually TIPS is being done as last result to control the bleeding.
Absolutely.
And
so in
also
this
a
case,
bridge.
not done the initial steps because you have straight away went to the last resort. So what else you can do?
Yeah.
Tamir?
Well, bleeding varices, I know that the esophageal varices, but the rectal varices, the patient when he presented, we give the telepressin and then
Very good. Absolutely. So you give pharmacotherapy in the form of terlipressin, or you can give octreotide injection infusion. One. Second thing, you still do the same like an esophageal varices. You do an endoscopic banding if you can. If not, you can always. The third thing is like how you do the esophageal varicose. You put a zinc stick and Blackmore tube. Here you can put a Foley's catheter, inflate and keep and see what is happening. Because suturing is not going to help. Yeah. So you need to go and find the proximal varices where it comes, and you need to band those so it stops the end. Okay, and then you do this Foley's catheter. If it doesn't work, you go and do a TIPS. Okay, so I'm going to stop you here. This is a typical simple case, okay, of how the scenario can lead to. Okay, so none of the scenarios in the exam will be very straightforward. Either the diagnosis itself is a different diagnosis leading from something. So here, Abdullah again failed to express his higher order thinking. Yeah, he was so focused on bowel cancer that even after giving several clues, looking at the blood test, looking at there is pancytopenia, still he wanted to push and do a colonoscopy because his mind was just focused on this. So this is where the higher order thinking comes in. Okay, again in the exam, it is like a discussion between two colleagues. Most of the examiners would be like me, who will be friendly, who will be trying to help and have a discussion. There will be some examiners who will be really rude, I would say. Okay, they will be, whatever you tell, they won't accept. Whatever they will try to, put you down. So those kind of examiners also will be there. So you need to make sure that you take up the clues. The examiner will try to help you now and then. The examiner will never sit at you going on in a completely wrong direction. When the examiner gives you a clue and he stops and asks you a question, think twice before you answer to see whether the examiner is trying to correct us or not. That's one thing. And the second thing is, again, when you will be having at least 10 to 15 images which will come in your exam, starting from CT scan to MRI to MRCP to X-rays to something. So you need to know in and out of abdominal and chest radiology. You need to know everything. Okay, so majority of the short cases in the Viva will start with an image. So you have a 43-year-old coming with an abdominal pain, this is the CT scan. You read the CT scan. From the CT scan, every discussion will go forward. So you have no excuse from preparing yourself in knowing how to read and how to diagnose. So you need to do lots and lots of exercise on these things. Okay, so again, this is a very typical long case where things can go. Again, irrespective of your specialty, you can have any long case. Okay, for example, you can have a long case, a very common long case which used to come for everyone is a breast case. Okay, like last two exams, not the previous one, the previous two exams, you had a patient who had a bilateral mastectomy with multiple flaps. Okay, coming as a patient, and they discussed everything about the familial breast cancers, prophylactic mastectomy, flaps, etc., etc. Even though you are not a breast consultant, okay, as per the syllabus, you are expected to know up to an ST6 knowledge. So you need to know a good knowledge about the basic things. What is how you differentiate a specialty topic between a specialist and a non-specialist is only the trials. Except for the trials, which a specialist should know in that particular specialty, the rest, everything you should know. The basic treatment principles, what are flaps, this and that. For example, last exam, there was a case in one of the long case where a patient who presented, who had a total colectomy, distal pancreatectomy, left nephrectomy, coming with some tumor. They started with a CT scan showing a retroperitoneal sarcoma. From the retroperitoneal sarcoma, they went into intra-abdominal desmoid, and the complete discussion was based on desmoid tumors. Okay, so this is how the scenarios will go here and there, and you have to make sure you keep your mind wide open. Okay, if you think that the scenario is very, very straightforward, then and you're answering in a very straightforward fashion, it means that you're doing some mistake. Okay, so it will not be straightforward. Either the scenario will be complex based on the diagnosis, or it will be complex based on the patient's background. For example, the same patient coming with bleeding PR, they'll tell that patient is taking warfarin with a metallic valve. Okay, and the metallic valve was placed 6 months back, and you want to stop warfarin while the hematologist and the cardiologist are telling, if you stop, he's going to clot. What are you going to do? So this will be a situation. So this is how the situations will become. Or the same patient will have a learning disability or dementic. So how are you going to deal with the situation? This is how the situations will twist here and there and do things. Or if it's a HPV patient where you want to do an MRCP to make a diagnosis, they'll tell patient as pacemaker, you cannot do an MRCP. Or they tell patient is claustrophobic and doesn't want an MRI. What are you going to do? Or patient is morbidly obese, he cannot fit into the machine. What are you going to do? So this is how complexities will come into a simple scenario. Okay. Any questions? But Abdullah, you did well. Yeah. But as I told, you need to have this higher order thinking. Keep your mind open. Tell everything possible which runs in your mind. Yeah. But the way you obtained history in a very quick fashion was very impressive. With 3 to 4 minutes, you were able to gather many things, which is more than enough for compiling and put together and come with a differential diagnosis, which is good. Right. Any questions so far? No? Right. So let us move on to another scenario. Okay. So who wants to take this up? Apart from these 3 people, these 4 people then. Okay, Vishal. Right, Vishal. So you are the consultant on call. Okay. And you are facing a situation. You took a patient to theater. Okay. Who is a 24-year-old male who presented with peritonitis. You did a CT scan which is showing a pneumoperitoneum. Okay, and the CT scan was reported by an ST2 registrar telling that it's a duodenal perf. You went there to the theater, you go in, okay. So tell me the surgical steps. So this is the patient, you are going to do the operation. What are you going to do?
So that's the steps of the operation, is it?
Yeah.
So he's a 26-year-old male. I would go with my comfort zone of laparotomy, keeping in mind with the history, either it could be duodenal perforation or an enteric perforation. So midline laparotomy, then control of the biliary spillage, adequate suction, thorough lavage, looking into the exact site where the perforation is. If it's a DU perforation, making sure whether the edges are healthy.
Where do you normally expect a peptic duodenal perforation?
D1 or pre-pyloric region. Yeah.
D1 or pre? Both are different.
D1.
D1 or D1. Okay. So imagine you did a laparotomy in this case. You see that there is some pus in the right, some diaphragmatic region and in the Morrison's pouch. You can see some bile with some, fibrin deposits. But you cannot see, you are seeing the distal pylorus and D1, but you can't see a perforation.
So
but you see that the D2, the colon, is all forming a big inflammatory mass.
then there could be high suspicion of a retroperitoneal perforation, wherein the perforation is in the posterior wall, and I'm not able to see it in the anterior wall, and everything is getting collected retroperitoneal, which is making the whole mass of the colon and the D2, D3 junction.
So what are you going to do?
So,
Let me mute. Yeah.
So I will still go forward with what I'm comfortable with and make an incision on the D1 and try to see whether there's a posterior wall perforation. And
so you told that you suspect a perforation retroperitoneally, yeah?
Yeah.
D1, is it retroperitoneal or intraperitoneal?
Yeah, in the sorry, D3.
So you will make a hole on the D1 and go inside and see? What else you could do?
I could do the cauterization of the duodenum and check for the.
So before cauterization, how are you going to expose the C loop of duodenum? You know, the C loop of duodenum you cannot see straight away, isn't it? Something sits on the top. What is sitting on the top? The colon, isn't it? Transverse colon and the hepatic flexure. You need to bring down the hepatic flexure to see the colon. So what is that maneuver called? It's called cattle brush, yeah? So you do a cattle brush maneuver. You brought the colon down. You see that the posterior wall of the colon, pancreas, and the duodenum are all stuck. So when you try to bring down the colon, you see a big pus cavity which opened up with bile. Okay, you clean all these things, okay, and you see that there is a big hole in the second part of duodenum, which is probably a big diverticula in the duodenum lateral wall, which is perforated. You can see a mucky duodenal diverticulum, which is necrotic, perforated, and big pus cavity is there. How are you going to manage this?
Considering that the patient is quite septic, and if it's a very mucky, ragged edges D2 perforation, which is not amenable to primary repair, I would give thorough wash and everything, clean the peritoneal cavity, control the source of sepsis, and do a tube duodenostomy and put drains in the right upper quadrant region and in the pelvis.
So what is tube duodenostomy? What tube you will use?
Either the Foley's catheter or drains, Robinson's drains.
So this patient, as I told, almost the diameter is like the entire length of D2 is opened. It's like at least say 4 centimeters long. What will you do? You are in the middle of the night at 2 o'clock. You have seen this, you have washed it out, and you see this big hole, and you see an ampulla nicely, which is leaking bile inside the duodenum. What are the options?
In the middle of the night, it's difficult to do.
Difficult to do what? Whipple?
PPPD.
So you are planning to do a Whipple. So what specialty you are in?
Colorectal.
So you, as a colorectal surgeon, you would think of doing a Whipple at 2 o'clock in the night?
It's out of my question.
Okay.
It's of my option.
Okay. So this is a real life scenario, yeah? It can happen to anyone at 2 o'clock in the night. What you will do? What will be your next step? So you don't know what to do, which is absolutely fine because you have never seen the situation in your entire life. What you will do? You will call for help, isn't it? Whoever is sleeping, you will wake them up, yeah? So you wake, say, one of the HPV surgeons or someone, and you ask what you need to do, okay? You will tell this in the exam, but the examiner will tell you no one is picking your phone call.
Okay.
What you will do?
Damage control surgery.
Yeah, so what you will do? Exactly. What you will do? What is damage control here?
Just to control the source of sepsis.
Absolutely, very good. So what you will do?
Just put the drains in.
Absolutely, you just put a drain and come because you don't know what to do here. Yeah, your aim here is to make a controlled fistula of whatever is leaking. You put 2, 3, or 4 drains, how many ever drain you want put there. Come out, refer this patient to HPB. That's all you will do. Okay, nothing else you will do. Imagine, before I move on to one of the HPB trainees here, so imagine you cauterized and you can't see any hole there in the entire D1. So D1, there is no hole, D2, D3, nothing. And you lifted the transverse colon, you ran from DJ flexure to ileocecal junction, everything is fine. What will you do now? No perforation you identified.
Again, I think I'll keep drains in and then come.
Where could be the perforation? Which area you have not seen yet? In whatever I had mentioned.
The rectum.
Indeed, you think your rectal perforation will have bile in the abdomen?
Oh, no. You've seen
Lesser sac. Lesser sac and posterior wall of the stomach. Yeah. So posterior wall of stomach is something where you always need to look into in any proximal GI perf where you can't identify. It could still be a cancer perf or even a peptic gastric perf in the posterior wall, which unless you open the lesser sac, lift the stomach and see, you cannot see. Okay. Any HPB trainees here? You can. Amir, are you HPB?
At this time, unfortunately, yes, sir.
This time you are unfortunately yes. No, are you a HPB trainee? You are giving exams at HPB?
Yes.
Oh, perfect. Right. So Vishal has called you and you had come in now. Okay. And you see this big hole on D2, which is on the lateral and posterior aspect. And you see that the ampulla is just, say, 1 centimeter from the posterior edge. What are you going to do now?
So initially the damage control surgery has been done. He's contaminated.
No, leave that. No, he is calling you during the initial operation itself because you are a specialist. So you are a HPB surgeon. He didn't have experience with the HPB area. So you are being called in. You see this big defect in D2. What are you going to do? It is in the posterolateral aspect of D2.
I think at this point, I must still do a T-tube.
Where will you put a T-tube here? As I told, he can't even put a big Foley's catheter because the hole is so big.
I think it's going to be a bit tough if I actually, at this point in time, because if there's an involvement of any area near to the ampulla, they've been thinking about a big Whipple, but obviously I want to make anything shorter than that.
Of course, you are not going to do a Whipple.
Yeah. So the question then would be, if I just give me a few seconds. Ampulla.
Are you drawing and seeing?
No, I'm literally just, I've never come across this thing before. So I'm just thinking if ampulla is there and I have to literally deroot this thing at this point in time, defunction. The options, that's going to be some pyloric exclusion if I could do, but that would not,
Okay, anyone who wants to answer?
Any wedge resection if it's away from the ampulla and do primary repair, but depending on how close it is.
No, how can you do that?
No. Or probably hepatoduodenostomy is the best option I could do at this point if it's.
So you're going to divide the bile duct and do a chain. What happens to the pancreas?
That's a big thing.
No, it's not even a big thing, but still you're not addressing the pancreas, isn't it? Anyone else? Any suggestions? Yes, Qasim, tell me. Unmute yourself. Are you, what specialty, Qasim, you are?
I'm colorectal.
Okay, what do you think are the options?
I might be wrong, mainly because of the proximity to the ampulla, but I think in this situation, a polio 2 gastrectomy, where you just divide the distal or antrum of the stomach, staple the duodenum, and basically, and just do a hepaticojejunostomy.
What happens to pancreas?
Sorry, not hepaticojejunostomy, like a gastrojejunostomy. Pancreas will still be draining into the D2. Sorry. D2, sorry.
But the D2 is open, isn't it? Okay, anyone?
I think stent or something.
Can you do a vaginal
Can I say something?
Sorry. Let me ask. So, Chris, you have any answers? No. Mohammed Osman?
Yes, I think the best option would be to bring a loop and do a duodenogenostomy.
Absolutely. That's definitely the best option here. And the only option you are left here is doing a duodenogenostomy. You can bring a rule loop and anastomose the jejunum to the duodenum. Okay. And of course, this is not a non-HPV surgery. It should be done by HPV surgeon. I would prefer, especially if it is close to the ampulla. You need to make sure that the ampulla is not damaged, and you can do a duodenogenostomy. That's the only thing which you can think of, apart from doing a damage control, putting big drains there and coming out. Amir, do you accept that?
Yeah, no, it's fine. I think the whole question around was if it's near to the ampulla, then you're thinking about an anastomosis here.
Yes.
Yeah.
So as I told, the ampulla is say 1 centimeter away from the posterior edge. Yeah. So what you need to do is, of course, you need to put a small feeding tube into the ampulla and make sure, like how you do an ampulectomy. Yeah, that's again a question to you, which I will screw you when you, sorry to use the word, when you do the HPV Viva, I can tell you. So ampulectomy is again a very common question in the exam, the surgical steps of ampulectomy. So how you do an ampulectomy is making sure you put a feeding tube into the ampulla and make sure that the stitch doesn't go into the back. The same thing, you put in a feeding tube into the ampulla and you can do a duodenogenostomy. Okay, so the reason why I brought this here is not to tell, so having such a complex scenario in the exam is rare. However, you will be provided a scenario where you have a DU perf, but you go there and you see a big hole. Okay, like instead of say 3 millimeter, 4 millimeter, you have a 2 centimeter hole. So, okay, so one of the options which no one thinks of is doing an take a bowel and do an anastomosis. Okay, so another common scenario which very often asked in the exam is a perforation at the DJ flexure. Several times we had asked the situation where patient presenting with peritonitis, you go there and you see that there is a 1 centimeter perf on the DJ flexure. Okay, so yes, primary closure is an option. You can still take an omentum, do a primary closure. That's an option. If that is too big for a primary closure over an omental patch, then the options you have is you can do a Foley's and stuff. But the best thing is you cannot resect there and anastomose, right? Because you won't have much of a mobility there to resect and do a primary anastomosis. So in that situation, again, take a loop and do an anastomosis on that rent is a definitive way to get out of that situation. Okay, so perforation of the DJ flexure. So we had 2-3 situations where a patient presenting with DJ flexure perforation, they discuss about in a kind of a long case, they discuss about how you repair such a perforation. From there, they move on to what are the reasons for DJ perf. From there, they go into gastrinoma and they discuss on the gastrinoma. How do you diagnose gastrinoma and things like that? So this again a common scenario which has come in the exam. Okay, clear? Any questions? So I'm going to stop here, okay? Just that, so what I tried to do today is to give 5 different scenarios. So one scenario, we started with a difficult situation where we discussed about what is when we higher order thinking, how important is the landing sentence, and we discussed how the questions can go from simple things to a complex thing. We discussed 2-3 things about ethical principles and where you need to use those catchphrases, which is very, very vital for this exam. And then we discussed a situation where how a long case would happen, where there will be only 2 cases in your exam where you will be interacting with an actor or a patient, which will be the long case in your general surgery, long case in your specialty, which we discussed, and how again your higher order thinking didn't help, and how one particular finding led on to a different finding, and interpreting the images we discussed. And then a complex surgical scenario asking you about surgical steps. So how you will do, what you will do, real-time situation. So again, in the exam, the main reason why I want to discuss about the last scenario is you need to be safe. Okay. I know Vishal told, because it was a very, a social kind of a discussion, you told, I don't want to do a Whipple in the middle of a night. But hearing a Whipple in this case is a definite fail. Yeah. So you need to be very, very safe. Okay, that is what we want. We don't want a strategic surgeon or a powerful surgeon. We just want you to be a very, very safe person. So what you can do, so safety is irrespective of whatever is the specialty you're dealing with, your aim is to save the patient. You do whatever is minimum necessary or maximum necessary to keep the patient alive. And then the next day, the specialist will come and take over. So whenever the important way to escape in the exam is, you can very well call your friend. You can tell that I have never encountered that situation. I want to speak to my friend. Call. The examiner will tell. So that is the right answer in the exam, rather than thinking and wasting time. Yeah. Good. Mustafa, any questions?
Yes, in the scenario of the I'm an upper GI, but in the scenario of the D2 perforation, large one, if the patient is stable and I, as an upper GI, said that I want to do a serosal patch or the anastomosis, would it be like a safe option, or I shouldn't go through that pathway?
No, absolutely. It means anyone for that matter, if you can do a safe primary closure, you should do it wherever it is.
No, I mean, like, if the injury is a D2 and I don't think it will close primarily. If I said like an anastomosis,
you can't tell that.
I can't tell that.
The examiner will ask what specialty you are having, means you can tell that. See, for example, hot cholecystectomy, very common question in the exam. They will ask you, will you do or not? Okay, so hot cholecystectomy is something which even a colorectal surgeons are trained to do. Okay, and if you say that, yes, I'm upper GI surgeon, upper GI and HPB recently only got separated. Yeah, only for 2 years back. Before that, upper GI and HPB were together. So you can tell, as long as you can confidently tell in a way that you had seen one.
Okay.
But if you think that you will be caught, you can tell that I'm not going to do.
Okay. Thank you.
Amina? You there, Amina? You raised your hands, Amina? No? Okay. Good. So I think you felt useful. Chris, any feedback for today's session?
I thought it was good. I enjoy being put on the spot a bit. The landing statement, yeah, you said about not just repeating back, so you can't just, it's tempting for the landing statement to be the information you've just got, so that needs to be something new, but also pointing where you're going. So that was my takeaway.
Absolutely, yeah. So that's fine. So this is just an introduction, it's just a starting point, which we have just started just to know things. So we will be doing a lot of, I think most of the candidates here are our course registered participants, if I'm not wrong. So we will be doing lots and lots of exercise, in the next 3 months. Everyone will have at least 1 hour of practice every weekend to master these skills, and we will try to tell the tips and tricks everywhere. And I hope you're also finding the Telegram group very, very useful. Yeah. Again, whatever we are doing now is just very, very simple. As once the course starts, it will be even more intense, and we'll be discussing lots and lots of facts there. And we are trying to keep it in a way that at the end of just before the exam, you can just need to go through those things for you to revise and go for the exam. So I can only see 2 or 3 people actively participating in the Telegram group. So I would sincerely request everyone else to participate, because as I told, the weekend vivas are aimed at correcting your answering skills rather than imparting knowledge. We are not going to waste time teaching things on the weekend. We will be correcting how you are answering, and we will tell this is what you need to go through. You have to do the homework. Lectures are something, again, where we'll be quickly reviewing the important areas, what questions we'll be asking and what things. But most of the knowledge and the complex concepts will be discussed in the Telegram group. So please make sure to utilize the Telegram group. Yeah. Qasim, you have any questions? Can you unmute yourself, please? Sorry, mate.
Yeah, sorry. I just wanted to just clarify one thing. As we keep on saying that from us, what they want to know is, am I a safe surgeon or not? So on many occasions, like when we come across a situation like this one, that the D2, and you said, so if, and we keep on saying that if I'm not confident, I will say, I will do the damage control, put the drains, come out. Or I will ask a specialist or a friend to help me in this. But then the next question comes that, oh, if there's no one available, no one is picking up the phone, and
Yes.
I will say that I will not proceed, I will put the drains, I will come out. But they keep on prompting you that, they want me to do something. So is it
Absolutely.
right that I keep on insisting that I'm not going to do anything more? I think this is my limit. I'm going to finish here. I have tried all the help and no one is available at this hour. I'm still doing what I have decided, that I'm just going to stop this procedure without doing any more damage to the patient. So my question is, despite of their keep on asking and insisting, is it right to just stop there and telling them again and again that this is my limit, I'm not finding any help, and I'm not going to do anything
Absolutely.
silly?
Absolutely. They will
Yeah.
tell you. You will tell that I will call for help. They will tell no one is available. Then you will call, no one is answering. What you will tell, so you need to tell that this is out of my specialty. My priority is to save the patient's life. And in this situation, I will put a drain and come out. Okay. The same situation comes in a different way in trauma, for example. So here, you just put a drain and come, patient is going to be alive. Yeah. But say in a trauma situation, say you took a patient to theater, say a patient is hemodynamically unstable, and you are in a district general hospital, and unfortunately this patient who should have been taken to a trauma center but accidentally lands in a district general hospital which has never handled a trauma case. And this patient is hemodynamically unstable. You took the patient to theater. You opened up, say there's a massive bleeding from the retroperitoneum. You packed it, you took it out, still it's bleeding. What you will do? Yeah. Although you have never done in your life a single supraciliac clumping, you would be expected to do a supraciliac clumping here. Because this is a life-saving procedure. That is a damage control, whether you have done or not. Same thing comes in a trauma situation. Patient presenting with a stab. You are the consultant on call. Patient arrests in A&E. Although you are a district general hospital which has never done a resuscitative thoracotomy, you are expected to do a resuscitative thoracotomy. Yeah. So those steps you need to know. But these things, it's fine. So whatever is going to keep the patient safe, you need to do. In situations where, say, for example, they might ask you how many supraciliac clamping you have done. They tell, I have never done single one, but in this case, apart from doing a supraciliac clamping, I have no other option, so I will go ahead and do it.
Yes.
Clear?
Yes. Thank you.
Good. Any other questions, guys, from others? Anyone? No? So if not, we will wind off today, and probably we'll meet again tomorrow with a different set of questions, and we will do and continue your practice in the Telegram groups. Okay. Thank you.
Thank you. Thank you
Thank you very much.
Thank you. Bye.
Thank you.
Thank you very much.
Thank you. Thank you.